Good morning, everyone. Very good to see you back in this room. We hoped you enjoyed yesterday's sessions, all of them, including the plenary and the split sessions, and also this morning's abstract sessions, which are very, very interesting. We also got a chance to attend some of them. Welcome to this second plenary, which has an ambitious title, which we hope will be very reaching for all of us. What to finance first? Priorities and investments in financing. And when we were discussing with the colleagues from EHMA, what's the main scope of this plenary, I remember Federica saying, think of a plenary that will get the audience to know Romania. And we wanted you to know us, but also to tackle a challenging and technical subject. So we thought, why not financing? Because all our ideas, all our innovations, all our measures that we propose, they cost money at the end of the day. So what better way to know a system in 1 hour, which is anyway ambitious, than understanding its finances and its priorities in financing. So for that, we chose this title and this theme of financing, and we encourage you to be a very interactive session. I would suggest to our speakers to have a relaxed session, to be as frank as possible, and to still be cautious of the time, to keep some time at the end for an open discussion. And I'm encouraging you all to think of questions for our panelists, because we have a very valuable panel here. So before starting the plenary, please allow me to introduce our panelists here. We will start the conference with Associate Professor Diana Păun, Presidential Advisor on Health, who will open the session and also share her technical perspective as a professor in healthcare, as a former manager. And we will continue with a technical presentation. It will be a joint presentation by Professor Cristian Vlădescu, the Director of the National Institute for Health Services Management, together with Dr. Joseph Figueras, the Director of the European Observatory on Health System and Policies. We will then have the perspective of the National Health Insurance House through the intervention of Ms. Larisa Mezinu, the Vice President of the National Insurance House, which we thank for being here. And we will continue with Professor Federico Lega, professor at the University of Milan. And last but not least, my colleague, Dr. Ștefan Strinciuc, researcher at Iuliu Hațeganu University of Medicine and Pharmacy in Cluj-Napoca and honorary advisor to the Minister of Health. I would also like to say that the minister unfortunately will not be able to be here today, as the government meeting was scheduled at this exact hour. So unfortunately the minister will not be able to join us, but he will join us later in the afternoon for some other sessions. I would also like to say, before passing the mic to our speakers, that sometime during this session we will have ad hoc welcoming word from the rector of the Polytechnic University in Bucharest, the host of this meeting, Professor Mihnea Costoiu. He will join us at some point during the session to say a few words and to welcome you in Bucharest, as he couldn't join yesterday for the opening. Without further ado, I would like to pass the mic and the stage to Associate Professor Diana Loreta Păun, Presidential Advisor on Health.
Thank you, Theodor. Good morning, everyone, esteemed colleagues, distinguished panelists, and honored guests. I'm deeply grateful for the invitation to speak at this year's European Health Management Association conference. It is a privilege to share this stage with such esteemed professionals and to engage in this critical discussion about our collective future in healthcare. The topic we are addressing today is not only relevant, but fundamental in our quest to provide universal access while reducing costs. While the detailed rationale of prioritizing funding and investment in health lays with the Ministry of Health as the governmental executive institution in the field, my aim, according to the presidential mandate, is to share some strategic considerations to shape our future discussions. First point is that this discussion on prioritizing paradigm extends both within and outside our healthcare systems. Investment in health is a necessity, not a cost. investing in health is not an expense. It is a vital investment in our society's future. While there is undeniable competition for limited resources, health must take precedent if we aspire to achieve sustainability. Secondly, we need to understand the current landscape in which we operate. Conceptual delimitations are essential before delving into what to prioritize. We must ask ourselves, we need to know whether our understanding of what do we found is the right one. To ensure we make informed choices, we must ask ourselves, are we financing disease or health? Our current healthcare systems often focus on a reactive, disease-centered model, which, while essential for managing existing conditions, is unsustainable, expensive, and frequently yields mitigating results. For example, the United States spends approximately $4 trillion annually on disease care, yet the lifespan of its population has been declining over the past 5 years. In Romania, the last OECD report highlighted that current health expenditures accounted for 6.5% of GDP, with nearly 80% coming from public sources. Hospital services represented the largest share of health expenditures in Romania in 2021, contrasting sharply with the relatively low spending on outpatient care. These statistics underscore the urgent need to shift our focus toward health promotion and disease prevention. Both treatable and preventable mortality rates in Romania are significantly higher than European Union averages. Behavioralist factors such as tobacco use, poor diet, alcohol consumption, and low physical activity contribute substantially to these outcomes. Moreover, air pollution adds to the burden, with a much higher proportion of deaths attributed to it compared to the European Union average. The Romanian president and the presidential administration have emphasized the importance of supporting the health system in the long run. Addressing prevention, early screening, and health literacy from early ages is of utmost importance. Health, as defined by Peter Sterling, is the ability to optimally adapt to challenges with minimal strain or damage. This encompasses everyday activities such as waking up, climbing stairs, and engaging in mental and physical activities. Furthermore, to prioritize health, we need to shift our focus from genetic predispositions to modifiable behavior, psychosocial and environmental factors that significantly impact disease risks and, of course, longevity. According to OECD report, approximately 46% of all deaths recorded in Romania in 2019 could be attributed to behavioral risk factors such as tobacco use, dietary risks, alcohol consumption, and low physical activity. For example, dietary risk, including high consumption levels of sugar and salt, as well as low consumption of fruit and vegetables, were associated with 25% of total deaths in 2019, the third highest proportion in the European Union. Tobacco use contributed to approximately 17% of deaths, 7% were attributed to alcohol consumption, and 2% to low physical activity levels. All these figures are on par with European Union averages. However, air pollution contributed to approximately 77% of deaths in 2019, over 17,000 of deaths, a significantly higher proportion than the European Union average, which is 4%. The presidential administration has put forward in discussion with the WHO the crucial relevance of understanding the social and behavioral insights, and even discussed the importance of conducting further researchers in a multidisciplinary approach via a dedicated center. I would add further relevance to the informed policy making if such center at some point will come into reality. Informed decision making is crucial when prioritizing health investment. Whether allocating funding or programming investments, economic evaluations guide us. Decisions made without evidence, without analysis, and explicit social values can have profound implications. Therefore, it is essential to base our decisions on rigorous economic evaluations to ensure resources are allocated efficiently and equitably. We must also consider whether traditional economic models are still valid when assessing health outcomes. Multi-year budgeting can support a better framework for sustainable investment and should be adopted on a large scale. Smart investments are essential to increasing access and lowering costs. Embracing frugal innovation in healthcare, doing more with less for many, can offer valuable lessons for high-income settings. By leveraging affordable technologies and models, we can bend the cost curve and expand access to care. Scaling up innovation and digitization are promising steps. Investing in digital health technologies and in vitro diagnostics is vital for strengthening health system resilience. These investments can improve health outcomes and offer long-term cost savings by focusing on prevention and early intervention. However, we must ensure that these innovations serve all segments of population, particularly the unserved, to avoid exacerbating inequities. Implementing value-based healthcare, value-based procurement, and pay-for-performance models can reduce costs and increase efficiency. However, we must assess Romania's readiness for these models and prepare our systems accordingly. In conclusion, prioritizing health over disease is not only a moral imperative, but also a practical necessity. By shifting our focus to prevention, embracing innovation, and making informed decisions, we can build more resilient and sustainable healthcare systems. At the same time, we need to work together to ensure that health, not disease, is the forefront of our invest strategies. Thank you for your attention, and I look forward to our discussions today. Thank you.
Thank you very much, Professor, for this inspiring message from the presidential administration. It's a bittersweet message because we still have a lot of challenges in Romania, but through innovation, through prioritizing well, which is the topic of this session, I'm sure we will be able to tackle them. But before moving to technical matters, also speaking about innovation, we have in the room, and I would like to invite for a short, spontaneous, welcoming speech, Professor Mihnea Costoiu, Director of the Polytechnic University here in Bucharest, a partner of the health sector, and a university which is spearheading innovation in all the systems, not only in engineering. Professor, you have the floor.
Thank you so much, and thank you for this invitation. It's a great pleasure and honor, Mr. Council of the President, dear guest. We are happy because you are here with in our university. I hope our infrastructure is useful for your Congress. Usually we have many events in our university. It's the largest university in Romania. You are in the largest university in Romania, 40,000 students in a lot of domains. We don't have medicine for the moment. We have medicine only in the second center in Pitești. But we are very close with our colleague from University of Medicine, and we work for many years in common for realized project. I have two message, and I insist in our discussion with our colleague from the healthcare system about the combination, the interdisciplinary project between the doctors, in general, the medicine, and the engineers. Now, you know, better don't exist medicine without technology. And for us, it's very important. Can you talk about the management of the ecosystem, the healthcare ecosystem? It's very important, it's our opinion, to talk not only about the hospitals and the doctors. It's necessary to talk about the whole ecosystem, and the technology, it's part of this ecosystem, it's in our opinion. And can we talk about the investment? And Professor Paun mentioned it's necessary to understand the importance of engineering in the hospitals. It's important to understand and explain in front of society what's happened with technology in our life, not only in healthcare system, in general in our life, and what is the advantage to use the high technology performance in the next year. We are very good center in our university, very good research center. We work, we realize human organs in the 3D printing and so on, many investment. We are very good in biotechnology. We have very good school with the University of Medicine in biotechnology and medical engineering. And we are very, very happy to increase our participation in this large ecosystem. Thank you so much for coming in our university. It's a great pleasure and honor for us. Thank you so much.
Thank you very much, Professor, for taking the time to be here and saying this message, and also to your whole team here at Polytechnic University, who was very, very supportive in organizing this conference. And the facility is wonderful for such an event. And I think I speak on behalf of EHMA as well here. We had a very good collaboration. Thank you so much. Moving to a bit of a more technical part of our plenary, I would like to pass the floor to Dr. Jose Figueras and Professor Cristian Vlădescu for a joint presentation on the health system financing here in Romania. Josep, you have the floor.
Great, thank you. Thank you very much. If you could put it on the screen, please. Thank you. It's a real pleasure to be here. Thank you, Emma. Thank you, Romania colleagues, to have the opportunity to share some thoughts about the Romanian health system from an outside perspective, free riding on the real expert, Cristian Vlădescu, here today. We called our presentation, should be on the screen in a second, Financing and Prioritizing Spending in Romania. So we put the Romanian system within a broad EU health system context that should serve as a basis of our debate. How much are we financing the system, and where should we be allocating those resources to get more value for money? I'll be using Diana Pound. Thank you very much, Professor. You already mentioned this measure product, the country health profile that the observatory is doing with OECD under the leadership of the European Union. And actually, I take advantage to thank not only Professor Cristian Vlădescu, but also Professor Silvia Gabriel Schinte, who were the country experts behind that work, as well as some of my colleagues like Nathan Shilton, who have been behind doing this kind of work. So our first objective is to introduce this series. They're very short and sharp and allow you to understand all EU countries within a broader framework. We know it's a bit of a risk in 20 minutes, 10 minutes each, to try to give a fair analysis of what Romania is about. So you'll have to believe, Christian, not me, about the final diagnosis based on some highlights, some figures, some graphs, to give you a bit of a flavor of what's going on. But already, Diana, you already gave us quite a good understanding of some of the main challenges, which makes our job easier. Okay? The next, don't pay attention to that, even if I put it on the screen. This is a bit of a framework that we are using. Is the Health Systems Performance Assessment Framework we developed with WHO and the Observatory, and tries very briefly to give you a sense of what are the final outcomes of the health system, right? Intermediate objectives and final goals. I'm going to focus on those in my presentation, plus the function of financing, and then Christian will focus on other aspects of the system, like on primary healthcare, public health, and so on. The basics here is that the combination of the governance, resource generation, health workforce, financing, and delivery, all going to delivery, will produce a series of intermediate objectives and final goals of the system. So the idea is, how do we explain the outcomes in Romania according to these various functions of the system? Understanding, if you see in the bottom line, at the bottom line, that of course there are socioeconomic determinants of health that will be as or more important than the health system in expressing life expectancy. We introduced at the very end, that at the end of the day, the health system is about meeting the societal goals. And perhaps a way to make a better case for more resources, Diana, is to demonstrate, as you were saying very well, that health is truly an investment. And health is about sustainability, it's about investment, it's about security in many ways. So that's the kind of two frameworks we're using, the country health profile and the HSPA. So the first part then is the health system's goals and objectives. Life expectancy, we heard that already. The average life expectancy in Romania is around 5 years under the EU average. There was a very positive increasing trend, which was interrupted like everywhere else in the pandemic, but also we need to say that it has been recuperated and now is about 75.3 with an average of 80.7 for the EU. So there is an important gap we need to address, and we'll hear more about that from Christian later on. This gap can be explained partially. This is data also from actually last year, the prior generation of the country health profile is explained by preventable mortality as well as treatable mortality. So what we're saying is, you can see here the rates Romania could do a bit better. We're saying is that, and Diana has mentioned these numbers as well, we're saying that there is scope in terms of prevention, there's a scope in terms of treatable causes. It takes a bit of time for the clicker to work. That gives you a better sense. Okay. For some reason, it's playing with me, this thing today. Okay. It's trying to make my life even more difficult. So in there you see that around 50% of the preventable mortality would be around the circulatory system diseases. Is anyone trying to mess me up? Yeah, thank you. Yes, leave it here, please. Don't touch it. I'm not touching it. You can see it. I'm not touching it. It's not. Okay. How do we do that? This is going by itself? Can we make a deal? I'll tell you next, and you guys take care of it. Otherwise, I remember it by heart. So you just, then you have to guess what I'm saying when it has to do anything with the slide, which is even more fun, right? So you wake up a bit this morning. Okay, keep it there. Around 50%, an important percentage of that preventable mortality is around ischemic heart diseases, not 50%. Around cancers, of course, stroke, and COVID played a very important role, as you would expect. Around the treatable, we got around 50% as well, circulatory diseases that with more effective health system, we could be treating. Okay, that's the basics. that obviously you can see already that, as been said by Diana already, the risk factors, the public health determinants will be very, very important. Oh, this is going very well now. Next. Yes. So now we talk about another dimension of the outcome of the health system, which is access. So we talked about health outcomes, we talked about preventable, treatable mortality, then we talk about access. This data is data which is based on household surveys, where we ask what is the unmet need of the population to use services, be it of accessibility, lack of resources, human resources will be an important point in Romania, of course, or financial barriers like out-of-pocket. So we can see we have a bit of a challenge there, and particularly on the low-income parts quintile of our population. Next. This, as I said already, is explained to a large degree by out-of-pocket payments. Although the percentage is not that high, is the average out-of-pocket, the private expenditure, be it voluntary health insurance, which is in Romania is very low, and out-of-pocket is around 15% on average for the European Union and around 21% in Romania. Very important to highlight that of that percentage, pharmaceuticals plays a very important role. Around 63% of this out-of-pocket actually is for pharmaceuticals. And we need to acknowledge the enormous efforts that Romania has put in place to actually have exemptions for the elderly, for the vulnerable populations, but still have an important impact, as you can see in this data from our colleagues in the WHO Barcelona office on financial protection. Effectively, we see that in Romania, around 12% of the households get impoverished, mostly because they have to pay out of pocket. So finance barriers not only have issues on access to services, as we heard, but also impoverishing their household budget. Next one. So you got really very rough, broad sense of the kinds of outcomes of the system in terms of financial protection, in terms of accessibility, in terms of health outcomes and preventable outcomes. Now let me give you a sense, because that's part of what we're talking about, of what's the role that expenditure may play on that, and the point that Professor Pound had said very effectively about the need to invest resources in our health system. This is a figure that you've probably seen before that shows Romania around half expenditure, half the expenditure, EU average expenditure, so around 2,000 PPPSs versus 4,000 EU average expenditure in the EU. Again, showing this 20% private expenditure versus 80% expenditure. The social health insurance, within that expenditure, we need to highlight that has a fairly generous package of benefits. But of course, it is what it is. If you spend 2,000, you cannot be as generous as you would want to be. Very important to highlight that 6.5% of the GDP is not exactly close to the EU average, or perhaps there is a powerful case to make a case for the Prime Minister, for the President, to actually perhaps put more resources out of the GDP in this area. Having said that, it's interesting to notice that since 2010, this is the rates of expenditure versus the rates of expenditure growth, public health expenditure growth versus GDP growth. And you can see that actually the health expenditure growth has been above the GDP. So there's an element of resilience. And I understand that recent data from 21-22, 22-23 are showing us that this trend continues. So there is an effort clearly there of putting more money into the health system. But that's, if you want to pay attention to one slide today, that would be the one that I think we need to, and I conclude here within my 10 minutes, we need to really be very sober and cautious when we talk about another country. That's something I learned the hard way. Humility, humility, and humility. It's easy to show some of the easy. It's obvious that some of the numbers and outcomes are really not that good. But colleagues, this is a very important figure today. This is a treatable mortality versus expenditure. And some experts would say that at very low levels of expenditure, there's no much room for value for money. The system collapses. I am not saying that, and I'm sure my colleagues would disagree here, many of you, There's always room for more value for money, for more reallocation. But at very low levels of expenditure, that's very difficult. This graph here shows that, yes, perhaps Greece, which is double the amount of Romania, gets quite good results on treatable mortality. However, we know that in treatable mortality, the data, avoidable treatable mortality, doesn't quite standardize very well for preventable, and perhaps our Mediterranean diet in Greece and other socioeconomic factors can play a role in that what is, in theory, avoidable through treatment, but as I say, we don't thresh out very well the prevention. What's really interesting here is that at the same level of treatable mortality, we have countries on one side, like Italy, Spain, you could say, Mediterranean diet as well, that spend less than a third of what Luxembourg or Denmark or Sweden spend. They get the same results for a third of the resources. There are many factors here. I know, you're all thinking about that. I know. But it makes you think, doesn't it? So my last point is we need to make, I'm sorry, the funds was where I got messed up. That's life. Should be bigger. So we need to be better at making and communicating a case for UHC here and elsewhere and investing on health. We now have a powerful case after COVID of health as sustainability, health as security, health as well-being. Having said that, it's not working very well because Cinderella, Health Cinderella, was with the Minister of Finance dancing, getting lots of money during COVID, but now is back in the kitchen. So these arguments are very, very important to get Cinderella Health back into the Ministry of Finance and the Prime Minister getting more resources. And we have strong arguments there. However, the President in Romania and the Minister of Finance will ask us, yes, we'll give you more money, but keep showing that whatever waste is in Romania and elsewhere, you are addressing it. Keep showing that there's value for money if you want more resources. We have experience. We work with many countries on that, with WHO colleagues and so on. And when you go to Minister of Finance and say, I want X for Y, you get a better chance, and I'm going to be saving on Z to get these additional resources that certainly Romania needs if it's to improve. Of course, there are other elements, as we'll hear from Christian, but we need more funds, and we need more funds also for this universal coverage. Christian.
Thank you, Joseph. Sorry. So, in terms of priorities, let's say the most important item to see what is prioritized, what is ranked first in a country, it's to look where the money are going on. And in Romania, the money are going for a long period of time on hospital care, and to be more precise, on inpatient care. You look at the total spending, Romania is spending less than half of the European Union average spending as a whole. At the hospital level, probably is the best situation in terms of comparisons with the others. We are spending like 60% from the European average. And if you look, I don't try not to touch too much. If we are looking on other items, we'll see that prevention in Romania, which is on the last part of the graphic, but also it's on the last level of spending. And long-term care are two of the areas in which Romania is underspending, even according with its own standards. We are less than 20 or 30% of the European average. So the discussion could be, if this is the situation today, looking and having in mind the outputs, the results which were mentioned until now by the previous speakers, if it's desirable allocation of resources. And we look here what we are doing with those resources in each part. Basically, Romania, it's covering, in terms of benefit packages, it's covering more for inpatient care than the European average, meaning that 99% of the inpatient care is covered with public funds in Romania, compared with an average of 91%. The others are, let's say, more or less comparable, with the exception of dental care, in which Romania is covering 7 times less than the European spending average. Now, if we are looking to what are the causes of these, let's say, not very good outcomes, not a polite way not to say that they are the worst outcomes in Europe in terms of health indicators, we'll see that the lifestyle takes great part in this situation, and the risk factors amount for more than half of all deaths. What was mentioned and described before as preventable mortality, and the dietary risk in Romania are 25% as compared with 70% in EU. Tobacco, it's the legislation, let's say, enacted in Romania, make it to be the situation like in the European Union. What is somehow almost double in terms of risk, it's air pollution, which is 7% in Romania, 4% in the European Union. And 7%, meaning that 7% of all the deaths are due to air pollution, and 25% for dietary risks. Physical activity, consumption of high levels of sugar and salt, mentioning salt, reducing the consumption of salt to the EU recommended level, to the WHO recommended level, will have an effect like treating 3 million people with hypertension, and this in turn, of course, will have an effect in mortality for stroke and for cardiovascular diseases. These are all these major factors which they are taken into consideration in the Romanian strategy, meaning that they are clearly marked there. Policies to address those major risk factors, I think still needs to be developed and implemented in full. I started saying that the Romanian health system is a hospital-centered system, at least if we look on the financing part of it. That means that a lot of care which could and should take part outside hospitals, it's neglected, and diseases like those from here, diabetes and asthma and COPD, are the patients are treated at the inpatient level, at the hospital level, for levels of care which generally could be taken care at the primary healthcare level. We have another indicators which is not mentioned here, the so-called avoidable hospitalization, which is something like 7% of the total hospitalization in Romania, higher than in EU, but not, let's say, double or triple, 20% higher, I think. And this is not, I try to be very clear, this is not to say that we don't need to do hospital care for those type of diseases. The hospital care is needed because we didn't develop the other part of the system, because in half of Romania, in the rural part of Romania, there are almost no medical facilities, almost no physicians. I think there are 400 units without any physician in Romania. We have here a diagram with the density of doctors and nurses, and Romania, it's even if it improves massively in the last 20 years, it's still under the European average, both for doctors and for nurses. Nurses are almost at the average, 8 nurses per 1,000 and versus 8.5 nurses per 1,000 in the European Union. The family doctors also are in a lower percentage in Romania, but the major problem is not the number in itself, it's the distribution of them. Half of the Romanian doctors are working in 6 cities in Romania, in 6 districts, if you want, out of 42 districts, including Bucharest here. So it's a huge imbalance in repartition of doctors. We also have a paradoxical situation. We have one of the highest number of medical graduates in Europe, both for doctors and for nurses, and still we are under the European average. And not the only one, but one of the reasons, it's the migration in Western countries, basically, in the European Union mostly. And this will increase the imbalance because, as everybody knows, if you have to choose to live in rural areas, it will be easier to live in rural areas from France than from eastern part of Romania. Easier in terms of adapting to the local condition, being paid more and having more facilities when you start to work there. So this very, very rapidly I try to synthesize the data we have. And for conclusions, I put it here, but I will leave it for the discussions at the end. But some of the points which worth mentioning are those dealing with the aging of population, which will put an extra pressure on the health system and on the financing of health system, both in terms of more patients, but also in terms of workforce which is becoming older in terms of percentage of people over 60 years. The risk factors, probably the lifestyle, is the one of the areas in which direct intervention and focused intervention could increase significantly and improve some of the health indicators. The unmet healthcare needs in Romania are double to the European average, and here we didn't have time to discuss it, but also the European Union surveys find out that the Romania are, when they were asked if they are satisfied with their health status, they are one of the nation most satisfied with their health status, even if they have, let's say, 8 years less life expectancy than Europe. That means that Romanians are a very optimistic people, and we can build on this. The expenditures, I don't enter to details. I will just mention that probably something has to be done to improve the primary healthcare area, not reducing other areas, but making them available, especially in rural areas, meaning half of Romania. So at the end, this is a question probably valid for every country in the world, from United States, which is spending trillions of dollars, towards less developed countries which are spending even less than Romania. What is the right level of funding, and who has to pay for it in order to have a sustainable health system? What will be the mix between public and private funding, between public and private provision and healthcare, and what should be the type of system which will deliver good quality health services without financial hardship. Thank you very much, and waiting for debates.
Thank you very much, Professor. Thank you very much, Dr. Figueras. I think this was a very comprehensive and honest overview of the Romanian health system in terms of financing. Yet it's important to have this honest overview, because in order to identify the right measures and the right priorities, we have to understand the overall data. And I would like to highlight one more thing, because one of the principles that we have here in Romania in many debates when it comes to financing is that we are all in the same boat. A lot of people tend sometimes, fight for that, for pieces of that pie, which is already insufficient. So what we try to advocate is that we are in the same boat, and we have to make a case, as Josep was saying, for better investment in healthcare and for an overall larger pie. And I want here to highlight one thing: value for money. And one of the things we are struggling with in the healthcare system is to bring other stakeholders outside the healthcare system to understand the importance of a better investment and a larger investment in the health system, like the ministries of finance and economists and so on. So the value for money concept, I think, is very important for us to understand in this. And in order to introduce the next speaker, I think Professor Vladescu made the perfect transition at the end, saying that it's important to invest in the primary healthcare. And here I would like to invite Larisa, who is the Vice President of the National Health Insurance House. They have a very difficult mission at the House, because they are the administrators of this insufficient pie, and everyone wants a larger piece of it. So Larisa, I know your experience here is very valuable, and please share some of it, including what are the reforms in order to improve the primary healthcare financing, as Professor Vladescu was saying. You have the floor.
Thank you. Hello, everybody. First of all, I'm honored to be part of as a speaker in this panel. And of course, when we need to speak about financing the healthcare system, often we speak about the National Health Insurance Fund, no matter if it is a social or a private or both funds. The fund is important. And in Romania, we do have a National Social Health Insurance Fund since 1999. And it is organized by a National Health Insurance House in coordination of the Ministry of Health. Of course, in present, from total expenditure, National Health Insurance Fund covers 67%, 21% represent payments made out of pocket, and the rest of it's covered by the state budget through Ministry of Health and the local budget. We hope soon we will have private insurance to fulfill that gap and to address out-of-pocket payments. And when a public institution like National Health Insurance House is asked what to finance first and how to do it, we like to say that the answer is very complex. But not to stress you out, I know time is limited. To put it in a nutshell, I'll say that the first step is to have a good plan. And we are lucky that we have a plan that we call a National Healthcare Strategy 2023-2030. And of course, we do have it on long-term perspective. That is important. And next, I think important is to have realistic objectives to follow and milestone to reach. And of course, all of this need to be based on data, evidence, decisions. And in the end, and not less important, is to have continuity in applying this plan. And we often see that the management it's changing more often than the milestones. So the continuity, it's for me, from my perspective, important in keeping the good work of that plan. Of course, when we see the national country healthcare profile, and we know it very well, we need to change a paradigm. And we started with more step in 2022. And I will say with important modification of regulation in the summer of 2023 to debalance the finance from inpatient care to outpatient care, extending the number of services provided in outpatient care, and to strengthen the primary and secondary healthcare sector from addressing diseases prevention, early diagnosis, treatment, and from the autumn of 2023 also immunization from the National Health Insurance House. I think it is a good plan, and if we add education for healthcare to people in school, and if we add awareness to community and population that well-being and healthcare it's a private good, not just a public politic, I think we are on the right pathway. Thank you.
Thank you very much. Thank you very much, Larissa. Indeed, the House, together with all the health authorities in Romania, have taken already steps in reversing that paradigm, changing the paradigm. But still, there is a big journey, a long journey in front of us. I would like next to invite Professor Federico Lega from University of Milan. Federico has been in Romania for a couple of times already in the last few years because he's part of the consortium that's supporting us in the project that was presented yesterday in order to enhance the management capacities of the people occupying leadership positions in Romania. Federico, please share with us your perspective from the management perspective of priorities in financing. Please.
Thank you, Theodore. Thank you for inviting me for this session, and welcome and good morning to everyone. Yeah, I will take my angle, which is also the angle of the process we managed together with the National Institute for the Service Management, Professor Fradesco, over the last month, but also is the angle of the conference in which we are, which is the management angle, basically. What to finance first? If you have to do a journey, you need fuel, right? And the fuel could be technology, could be facilities, could be financial resources. But what is the most important fuel if you have to decide where to go? What is the journey that you want to do, right? So I think it's people, right? And we have two sets of people in healthcare. We have the professional, those delivering, and we have the people serving those delivering. We have the managers, the leaders, those professionals coming to leadership, those that really could make a difference if we see actually what happened over the last 20, 30 years in many health systems developed. And what I will try to share with you is that power without control, the best professional without control, don't really make a system a good system. They make a decent system, they solve issues, but they don't make the system to make the leap. There was a commercial back in the 90s done by Pirelli. Pirelli makes tires, and their motto was, power without control doesn't make sense. It's dangerous. You go too fast, and we know very well that in healthcare, when you leave professional without control, there are moral hazards coming in place. There are opportunistic behaviors. I'm not saying this is actually the rule, but it happens most of the time. So money is not spent in the most proficient or the most effective ways. So people is the matter for me. Every health organization, every system will never be better than its professionals, but those professionals need to be assisted and managed in the best way to make them actually able to deliver the right care in the right moment, at the right people, in the right place, and so on. So if we look at what happened to health system over the last 60, 70 years, more or less, we were back in the 50s or last century, most of health organizations were what we used to call iatrocracies. So they were managed by doctors, self-managed. And the level of self-referential practice was quite huge. And we still have that in modern times when we look at artificial variability, how things happen within hospitals or within other centers. Then the system that react transform iatrocracies in professional bureaucracies. So they put administrative people to serve and to try to control those professionals. But the professional was stronger, and they make the administrative people basically serving them and serving their interests. So then we come to the 90s, late 80s, 90s, and the managerialization process in many systems started to take place. The point was, can we introduce a command and control chain within the system, making sure that those managing will be able, at least at the beginning, to control the behavior of the professional, steer them towards the good practice, and making sure that will be done in the interest of the system, and looking at the figures that Joseph showed us, improving the figures of the system itself. If I have to say, thank you, Joseph, because the table that you show us also explain why Italy sometimes should be invited to tables in policy making, because the result that we have certainly is part of the Mediterranean diet, and certainly health system counts only for 30% as a determinant of the health of a population. But we do have interesting stories to tell about what we did in order to cope with a limited amount of money put into the system. But anyhow, so the managerialization came in place, and that generated a lot of antibodies into the professional. I remember one day I was working in a large hospital in Veneto, and I was working with the clinical leaders of surgery. We were doing work on clinical pathways and reorganization of the departments. And then the new residents came in that day. Well, first day of the new residents in surgery, and they said, well, Federico, we need to stop, because it's my pleasure to show the hospital to the new residents. They were coming from different universities across Italy. So I say, okay, I'll come with you, because it's an experience for me also to learn how the hospital is organized and then go more in detail. So we start working on the hospital, and it was stopping and say, okay, over there's the pulmonology unit, and it's led by a great scientist, which is the head of the European Union of Respiratory Disease. Then you have the gastroenterologist as won this prize, and then you have the internal medicine doctors, which has been awarded a certain recognition. So it looks like we were in the John Hopkins hospital, basically, or something like that. The best hospital. Fantastic. You see, the residents are coming for the first day, and he basically was telling them, this is the best place where you could come. We got a great asset of professionals. Then we were walking through a alley, and there was a window, and through the window was another building, and he stopped, and he pointed the finger at the building on the other side, and say, and guess who stays over there? At the point, I was a little bit biased, so I thought, Nobel Prize, because actually this is the only things actually you didn't mention through the rest of the travel that we did through the hospital. I say, guys, over there are the people that generate problems to us. And obviously over there was the general management of the hospital and the administration. First day of the residence, just to make sure that you understand what you say, this side and that side, we and them. Okay, and it was in beginning of this century. So after that, we learned actually that maybe there's something different that we need to do, which is generating what we call collaborative leadership. So engaging the clinical leaders and the management and putting them on the same in the same room, basically. So generating what we call a diffuse leadership. And in order to do that, we need obviously to train the managers to accept the fact that professionals, the key asset, that they cannot just command and control over them, but they need actually to steer them and help them to become better leaders. But also we need to train the clinical leaders to become more proficient in managing what we call, or in understanding the challenges of health policy and health system configuration. Because health is a circular system, right? What I mean by circular system, what you don't do in prevention reacts in acute, and what you don't do in acute generate problem in primary care. What you don't do in primary goes in secondary and tertiary, and vice versa. And what you don't do in hospital get on the community, and vice versa. So you need to have a view about what happens, and most of our hospital clinical leaders are not yet ready for that, and vice versa. The community leaders often lack this idea. So we really need to do a huge effort to generate the right fuel for the journey the health system are going through. We can introduce the best technologies. We can build new hospitals. But then if we just relocate the old hospital to the new one without any transformation, it doesn't make sense. People will have better comfort, but the system will not improve. And the figures will not improve. So it's about fuel. So I think actually there are three actions that need to be done. Priorities in financing within the system. Some money needs to be taken apart and put for the fuel, which is people, which is both clinical leaders and management. We need to train from the beginning a next cohort and next generation of middle managers, those that are going to play a role in supporting the clinical leaders on the shop floor and the general manager. Those in operations, operation management, quality, those in clinical governance, those that do clinical engineer, and so on. Everything that actually it's in between and really could make a difference. We need obviously to improve the way we train hospital managers, but also we need to increase the way we train and generate community health manager. People working in between the governance system, the politicians, the primary care system, and making sure that a certain territorial population will be organized and assisted in the best way. What we call sometimes district manager, regions managers, that level is often absent in many systems, or is not strong enough. It's just sort of a replacement of position clinicians that just step in, but without really good knowledge about what does it mean to generate, for instance, population health management in a certain territory. What are the strategies that you can put in place? Third, we need obviously to train the clinical leaders, help them to develop less as managers and more leaders, which means actually helping the system to transform and do the journey together. But it's not just about training. Otherwise, I would say, this is my business, so I don't want to talk about my business, but it's about making attractive these jobs. The other thing that we have is that we need to pay the people going into clinical leadership positions and in management positions attractive jobs. This is something that I learned from the chief executive officer of the Rotterdam Hospital. Now, one day we have a conversation and I asked him, how much do you pay your clinical leaders? How much do you pay your management staff, the middle management? And he showed me the figures. They were impressive, really impressive. And I said, wow, I couldn't afford that. And he said to me, look, if you pay nuts, you get the job of a monkey. So if you really want the best, and if you want to attract the best in healthcare at hospital level, in the community, in the health authorities, you need to pay them well. As much as they could get if they go to work for a major bank or for a major company. Is it not as important work for healthcare than working for any other consultancy, bank, or should we actually do that? So I think actually part of the finance of the system should also take into account that if you want the best people, you have to recognize they're the best. And one way is also actually to make sure that they paid enough. So I'm going to close saying, we know by now that management does matters. There are research on that. We have shown that hospital and health organization better managed generate also better performance on the clinical side, but also, I give for granted from the resource utilization, but also on the clinical side. But increasingly, we know that leadership matters because in a transformative era like the one in which we have, think about the technology evolution, but also the expectations, the patient experience, the expectation of engagement of stakeholders. So healthcare will never be as it used to be. It's already under major change. We do need really people able to transform these visions into executions on the shop floor organization and running the system. So my point is we need to have all fuels. So good that we spend the money in facilities, good that we spend the money in technology, good that we spend the money in recruiting the best professionals, in training them. But if we don't have the other side, those leading and managing the system, organized and making it more fit for the future, we're going to still have a huge journey, a long escalation to do before we get to the point where we want to be. Thanks a lot.
Thank you very much, Federico, for this very inspiring talk. It's hard for me to stop on one message after your talk because the values that you just showcased are very dear to my heart, and I'm sure to many people in the room. I'll just tell you one short thing. When we did the strategy for health workforce in Romania, we also included a component on managers. And some voices were saying, why do you put managers here? Managers should have a separate strategy. Keep the workforce and do the managers separately. No. You put in a way better words than we could put it at that point. But we saw them as the fuel. We didn't have the word back then, but we saw them as a linked component of health, of the health system. So let me emphasize the money for fuel. I think it's important to leave this message in the room after this talk, that it's important when we think of investment, we mostly think of infrastructure all the time, or processes, or innovations, but money for fuel, it's important. And we care about this in Romania at this point. And hopefully it will be the same in the following years. And one more thing that I want to underline here is that community health managers, let me translate that for the Romanian context. For us, it's the local authorities, and I think it's important to showcase this. Most of our infrastructure is administered actually by the local authorities, not by any central authority. So it's important to bring them to the table. They were gradually brought to the table, but it's still not enough. So this is still something we have to work with, and you put it in a very nice framework. Thank you for that. Last but not least, I would like to pass the mic to Dr. Stefan Strilchuk, researcher, and I'm sure I said researcher, not the honorary advisor now, because you told me that you'll have a honest opinion as a researcher on the system, not from any institutional view. So Stefan, you have the floor.
Thank you, Theo. So it's always fun to speak last in such a panel because you have little time, all the nice topics were covered, and people want to go to the coffee break. But I want to approach this from a researcher's perspective because this is what I do in my day-to-day job. I lead the genomics lab. So what to finance first? To have space in the budget to fund something. Of course, one must also look at the big pressures our budgets are facing, especially if the pie is, of the same size. And of course, I fully agree with what has been said previously. What I want to, because we also need time for questions and debate, what I want to convey is a very simple message. I think that, so my hypothesis is that one of the reasons for our curative focus in the health system versus the preventive focus is that we are left with a big burden of the cost of innovation, the cost of research and development. And bear in mind, so innovation is great. It's the theme of the Congress. I wholeheartedly support research and innovation. This is what I'm doing in my job, as I've said. But I think that we end up paying a lot for the treatments that we use in our health system because we, at the end of the day, have to cover this very, very elaborate and costly process that is research and development. And, if we look at it historically, right, in the last couple of decades, costs with actual research and development, not in the health system, outside of the private or public, have soared. Like 20 years ago, 25 years ago, they were below 1 trillion, right? Way below 1 trillion. Now we're going towards 3 trillion already, and this is before the pandemic, so figures before the pandemic. What this means is that we're trying to do more, But are we really considering the value-based care in our labs? I can tell you from my perspective, no, we're just shooting at everything we can. Drug discovery, drug repurposing, and so on and so forth. So what is implicit in the reimbursement schemes that we are facing is that we are also covering the sunken cost for all the failed, interventions that we discovered. So one might say, well, such is life. So to progress, you need to fail. Well, what I am saying is don't stop innovation. How can health systems make sure that when we are covering this cost of innovation, that we are being more transparent, that we are considering some things like, as Dr. Paun mentioned, population coverage, so that everyone has access to this innovation. If you come to think of it, many years ago, right, when we stopped thinking of medicine in terms of humors, right, and we looked at the patient with the stethoscope and the microscope and whatever, when we had anatomical discovery, 18th, 19th century, the big barrier to that innovation was manufacturing, right? It was very difficult to get a microscope to a new lab. But then the Industrial Revolution came, so that wasn't a barrier anymore. Right now, the expensive interventions are not the blood tests that help us do a screening test or implement a screening program. They are the very expensive therapies that come from this super specialization that has occurred in the previous 20 years. And this is also linked to this big cost with expenditure, right? Cancer is not a general disease anymore. It's a precision disease. It's a disease of the genome. We need, even for the same tumor, some cells in that tumor might not respond to that treatment. So we really need to deep dive. Or, for example, gene therapy. SMA1 gene for spinal muscular atrophy, right? We are doing this. We're reimbursing it in the health system, but we are not looking at the value. So the end message I'm leaving you with, it's not only about HTA, because HTA is an ongoing, let's say, building site in Romania, and it was suggested as a solution. Well, I can tell you, and this is from experience working from the National Health Insurance House, when a parent will come with a child in a wheelchair, the cost per quality adjusted life year doesn't matter anymore. And then someone said, well, health is a political choice. Well, what I want to leave you with is that it's not only a political choice, it is a social choice. Our social contract, which means basically the rules that govern politics and also policy, health policy in this case, must be readdressed. And in Romania, for example, we're not looking at that at all. We just assume what people think. But our population is different than ones in the US, whatever, we have different distribution. So maybe, just to end on an optimistic note, I think, there is much room for innovation. I think innovation is the solution, but let's make it sustainable. Let's stop this uncontrollable spending, because I remember a paper from Professor Mosialos. It's really not the changing age group mix in the population that will be the big burden in the next 50 years. It's the cost of innovation. Thank you.
Thank you, Stefan. And I think the social contract leaves us on a very good stage for discussions. I know Emma will not invite me as the moderator again, but I take the liberty to run 10 minutes into the lunch break, also talking of prevention to avoid obesity. So I will do the mic ushering myself. And let's take some questions from the room.
Thank you. My name is Dragos Garofil. I really changed my mind. I don't want to ask a question. I really want Stefan's message to sink in the whole audience. I had a technical question for the professors in the panel. How reliable do you think the parity purchase power transformation is when comparing total health expenditure between countries? Because I really think it isn't, and the euro should be used when comparing total health expenditure. For example, Romania spends 800 euros per capita per year, Germany 5,000 euros per capita. And when PPP transformation, this big difference, this 7 times difference, it shrinks to only 2 times. So again, how reliable is PPP when describing healthcare expenditure? Thank you.
Thank you, Dragos. I have a feeling that Josep or Professor Bladescu would like to take the answer on this. Okay, yes, we can take 2 more questions and then have a round of responses. Any other questions? I'm sure the discussion sparked more questions. I have only one mic.
My name is Şule Kurt, and I am from Catholic University Leuven. And my question to Mrs. Larissa, yes, we saw non-communicable diseases are really common in Romania, but you said you are trying to strengthening first level and second level organization, which means primary care. And if I heard correctly, you said first level hospital, and I understood public health hospital. And at the same time, you have nowadays general public health insurance, but you are trying to get to increase private health insurance in community. In this case, my question is, when you say third level hospitalization, and I am understanding education and research hospital will be increased in Romania. So what kind of contribution can you, what do you think can contribute private health insurance to out-of-package payment in community? Because you said private health insurance will be contribute to the out-of-package payment in community. Thank you so much.
The back. We have one more question. Please.
Just one more question, gentle professors. I'm Damien from the Caribbean. What to finance first? Thank you.
Thank you. It's good to ask this question to the researchers, not to the policymakers. So we're looking forward for the response. Let's take a few more questions for the other speakers as well, if there are any, and then we'll have a round of responses. If not, for now, maybe the responses will spark more questions. Oh, one more question. Thank you.
Thank you. So smoking is one of the key challenges that you have. And I'm wondering what you're thinking around e-cigarette use in public health settings is as a prescribed service, which other countries have experimented with. I'd be really interested to hear your views on that.
Thank you. Indeed, tobacco control is a public health priority in Romania, and the e-cigarettes are an interesting topic. For now, I think we don't have any more questions, so...
Actually, I leave the answer to Christian. We were all arguing, but we both agreed, I think, with you. But that's what we got, right, Christian?
Since we have a common presentation, we also have common answers. So, in terms of the parity purchasing power, has a lot of biases, it's true, but this is the best we have until now. So, yes, you mentioned some of them, but we don't have another better option, let's say, to cover everything. We can, look on different aspects from different sectors, but if we want to have a comprehensive indicator, this is the best we have until now, with the biases, having in mind that there are biases and so on, and it's not really, the only figure you should have in mind. But it's helpful to see in the context, not to rely 100% on it and to base their decision only on this one. If we look on without these indicators, we will have completely other figures, for instance, in Romania, on costs. And it will be very difficult because it will even look worse than it looks on the PPP. So if we look on the let's say, the brute data, it's even more difficult to make comparisons. Let's say that this indicator, it's useful in having the general picture, but if you want to go into the details, sure, you have to look on very specific data you want, and generally this is what is happening. Yeah. People are looking onto the details, not on this one.
But not even that, within the EU, adding to that, within the EU, what are PPPSs? Good part of the expenditure is health workforce. And we know a doctor will be cheaper in Romania than elsewhere, but there's Ryanair, there is mobility. So for a doctor can go work elsewhere, double the salary, and come weekends with Ryanair. Sorry, I'm not now trying to make propaganda for Ryanair, but you know what I mean perfectly well. So you're absolutely right about the limitations, and Christian is right in the sense that's what we got. Let me try the question, your central question. That was the question we're supposed to address, right? What to finance first. I think there are two elements there. One, Stefan put it very beautifully, very nicely. It's a social contract, it's politics, it's a political economy. When you have a kid I remember a country called Chile many years ago as my first experience. They set up a package of care, and one particular disease was not included, a rare disease. A day after, a kid with that disease was chained in front of a president palace, and the day after, that disease was included in the package of care. So that's the political economy. It's a transparency, it's a social contract where we're prepared to finance or not. From the technocratic perspective, no issue. Primary care and public health determinants. That's the best value for money. But how can you go to the population and the kid with the wheelchair and the rare disease that needs the innovation and say, there's no money for you? This is the difficult problem that the insurance has, that the Prime Minister has, that your Minister has, and this is the problems we're facing elsewhere. But from a technocratic perspective, I think Christian and I were very clear where to put the monies.
Thank you.
I also want to have a short comment. I think that we have to analyze the data and the recommendation by our national specific, and I will give you a short example from my field of interest. I'm endocrinologist, and as you know, Romania has a huge problem. We have iodine deficiency, and a long time ago, the policymakers established a national program for combating this problem by iodinizing the salt. Now we have a recommendation to lower the salt consumption. But as endocrinologist, I have to put into balance the benefits for the population because of the iodine supplementation. So yes, we have to lower the consumption of the salt, but in balance, we have to supplement the iodine from other sources. The policy established in 1953 was real successful because in this moment in Romania, we don't have any more endemic cretinism, and our young people are more beautiful, more intelligent, and tallest than we were long time ago. So the specific of Romania is very important in interpreting this data.
Thank you. Because we have to wrap up the session in 2 minutes, I suggest to do the following. I will pass the mic to Larissa for a 30 seconds max response to our colleague's question. And then I suggest to leave the e-cigarettes question for the discussions afterwards. And I will end with a 1 sentence per speaker with a question from our colleague from the Caribbean. What to finance first? 1 sentence. That's the wrap-up. So Larissa, you have the floor, and then the wrap-up, 1 sentence.
So National Health Insurance Fund do not have competition on the market in Romania. And I think, and it's my opinion, that what out-of-pocket cover now, and there are dental services, pharmaceuticals one, can be covered by a private healthcare provider that could fulfill this gap.
Yes. Stefan, do you mind if we start with you?
What to finance first? Well, what people want, but we need to know what people want, and I think much more research needs to be put into that, because we are funding actually what people want, but we can also influence what people want.
Thank you. That's a long sentence, but yeah, thank you.
People, just people managing, people serving. If you invest in technology, but you invest more than needed, as many systems doing, without consolidation, concentration with the right mix. If you invest in new pharmaceutical drugs, but the access to the market is not regulated well, and people get the disequality in accessibility, I think it's about, there's a lot of opportunity yet at the system level to generate efficiency and effectiveness through the system. Think about the fact that we have 30 to 40% of specialty visit in many of systems required, which are not necessary, can be done by the primary care system or can be avoided because they're inappropriate. So,
thank you,
and the serving one.
Thank you, Professor. I'm just afraid Federica will kill me because they have a general assembly of EHMA in this room in a few minutes. So, Larissa, your 1 sentence on what to finance first.
Prevention, and to find a balance, prevention and a curative system.
Thank you. Joseph?
Already had the answer: prevention, primary health care, purely from a utilitarian perspective, value for money. However, from a political utilitarian perspective, there are many other elements you need to find, as Stefan is saying. However, cautious about what people want. People want hospital care. Are we going to finance hospital care? Or should we perhaps be far, 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 far better at communicating value for money, outcome and quality to that people, so they make the decision, but an informed decision?
Thank you.
As Joseph said, we already answered, but I would say it's basically a mixture between a technocratic decision and a political one. Needs assessment, comparative needs, if you want, felt need, and so on. So it's not only a simple answer, but it's even more difficult to try to design a system based on needs, on whose needs, and of course with whose resources.
What to finance first? Prevention and health education. This was and this is the first priority of presidential administration.
Thank you very much to all the panelists and to you for being here and for contributing with your questions. I'm sure the panelists will still be around for the discussions afterwards, and we have a lunch break now. So please enjoy the lunch and take advantage of the presence of our distinguished panelists. Thank you.